Hello, I'm Dr. Tom Appleton. Warm wishes to all of you from Canada. Very pleased to be presenting, and I'd like to thank the organizing committee and Professor Tafazal as well for the kind invitation to speak to you about safety of JAK inhibitors in the treatment of rheumatic diseases. We'll focus on past and present data that's available. Before I begin, regrets for not being able to be there with you in person, but I wish you all a fantastic conference. At the end of the session, participants should be able to identify the latest clinical trial results and real-world data published on safety of JAK inhibitors in the use of treatment of rheumatic diseases. And I'll just point out that we'll focus on rheumatic diseases, in particular rheumatoid arthritis in this case. We'll be able to consider these data when making treatment decisions for patients with rheumatic diseases, and we'll be able to identify risk factors that influence the safety profile of JAK inhibitors and consider these in your patients. Of course, there's a tremendous amount of literature available on the JAK inhibitor class, and it won't be possible to review all of that in a single presentation, of course. So today I'll focus on 5 major safety signals. We'll focus on MACE, or major adverse cardiovascular events in particular, as well as malignancy. And I'll also touch on serious infection rates, venous thromboembolic disease, and of course herpes zoster, which is well recognized as a risk with JAK inhibitors. So we all know that the oral surveillance study, which is the prescribed safety post-marketing study that was required by Pfizer to complete, but before that, we really relied mostly in terms of safety, at least, on long-term extension data from the clinical trials programs and real-world studies, largely registries, for trying to understand what the safety is in our patient populations. And so I wanted to go through this first because we sort of have this era before the oral surveillance program, and then we have the era after the oral surveillance program reported their final study results earlier this year. And I think there's an interesting contrast to discuss there. So what you're seeing on the screen is the long-term integrated safety analysis from the Tofasitnib trials program, the oral trials program. And this includes all the clinical trials, patients included, including the long-term extension for up to a total of 9.6 years. This was published by Stan Cohen's group in 2020. It's been reviewed a number of times. And essentially what we're seeing are the crude incidence rates here on the y-axis, and the blue bars are showing the range of observed events in patients who were taking biologic DMARDs or conventional synthetic DMARDs, just as a comparator, between the two rate groups. And of course, no surprise that herpes zoster shows an increased rate of events at 3.6 per 100 patient years of exposure compared to biologic DMARDs, which range between 2 and 2.5. But if we look at the rest of the adverse events of special interest, so serious infections at 2.5, tuberculosis 0.2, opportunistic infections 0.4, malignancies excluding non-melanomatous skin cancers at 0.8, and non-melanomatous skin cancers at 0.6, lymphoma 0.1, MACE cardiac events 0.4, DVT and PE at 0.1 and 0.2, mortality overall 0.3, and GI perforation 0.1. There really don't seem to be any major differences here between the Tofasitnib group and the biologic DMARD groups. I just point out the VTE rate here, which was actually a little bit lower in this study overall than other studies, which I'll show you in a couple of minutes, but just good to have this incident rate in your mind, 0.3. But overall, from this analysis, by comparing biologic DMARDs and Tofasitnib, there did not seem to be any major increased rate of adverse events of special interest in the whole oral Tofasitnib program. There's a couple of limitations, though, from looking at this, and I think we've realized now that even though the median exposure was about 3.1 years, this may not be long enough for some rare events that happen, even though there were almost 23,000 patient years of exposure in this study, a relatively shorter time of exposure may not have been enough. And I think the other major difference here is that this particular patient population was not highly enriched for cardiovascular disease risks, and that defines a major difference with the oral surveillance program. The first signal that we had for DVT and PE didn't come until the baricitinib program, and this actually occurred only in the placebo-controlled window, so the first 24 weeks of the study, and we can see it was only in the baricitinib 4 milligram group that there was an increased rate of DVT and PE, and the 2 milligram group was the one that ultimately ended up getting approved, at least in the United States and Canada. But in the extended arms, the rate remained similar between both groups at 0.5 and 0.6, and overall, throughout 9.3 years of follow-up, the baricitinib, all baricitinib groups incident rate for DVT and PE remained stable at 0.5. So really no new signals compared to the Tofasitnib analysis in the baricitinib program either. And there's the highlight from the long-term extension results that were published by Peter Taylor's group earlier this year. And again, you know, the rates of DVT and PE remain stable. So what about an active comparator? Well, it wasn't until the SELECT Compare study that which used the adalimumab active comparator versus upadacitinib that we really had a long-term safety with an ongoing active comparator arm. And so it's important to note that this data is a little bit limited. It comes from a single study, just the SELECT Compare study, but of course there were larger numbers of patients in this trial program. But we can see from the integrated safety analysis that was published in 2020 and updated again in 2021 by Stan Cohen that we have similar serious infection rates between upadacitinib and adalimumab, and similarly, or as expected, I should say, herpes zoster, of course, had a higher incidence rate at 3.3 compared to adalimumab at 1.1, but of course this was already known for JAK inhibitors. When we looked at VTE though, again, look at the same incident rate, 0.5, very similar to previous trial programs, and again, no difference versus adalimumab at 0.5. Major adverse cardiovascular events, incident rate 0.4 compared to adalimumab 0.3, and malignancy 0.8 for both upadacitinib and adalimumab. So again, no real differences between the JAK inhibitor upadacitinib here and the active comparator TNF inhibitor with adalimumab, and similar incidence rates overall to what we've seen in other trials. So this is looking at the RCTs, the long-term extension integrated safety analyses before we had oral surveillance reporting its final results. And aside from herpes zoster, really no safety signals for these three JAK inhibitors. And with apologies for not including anything about the filgotinib program, filgotinib is not and will not be approved in the United States or Canada, although it is approved in Europe. But at least with respect to MACE, malignancy, and serious infections, really similar results across these programs. So we had no particular reason to be concerned. What about real-world safety data of JAK inhibitors and compare this to biologic DMARDs in registry data sets? Well, this is another way to look at it, because there are patients who are not included in RCTs that we do ultimately end up treating in the real world. So the Core Avitis registry, which was formerly known as Corona in the United States, and they've recently changed their name, perhaps because of the coronavirus, not sure. But Core Avitis registry compared Tofasitnib versus biologic DMARDs in a 5-year safety analysis. And so what we're looking at here are the crude incidence rates for serious infections, herpes zoster, MACE, non-melanomatous skin cancers, and other malignancies, excluding non-melanomatous skin cancers here. And you can see the numbers of patients with events in each group here and the total patient years of exposure from there. But overall, there were 2,000 patients in the Tofasitnib exposure group, over 8,000 patients in the biologic DMARD group, with a mean duration of follow-up at about 1.5 years. So we can see that of course, the herpes zoster rate is higher than for Tofasitnib than for the biologic DMARDs as expected, but interestingly a little bit lower than from the RCT programs. And also the MACE rates a little bit higher at 0.6 than they were in the RCT programs. And one of the big differences in this group is that the average age in Corona registry is about 59, whereas it's about 52 in the RCT long-term extension study. So this may explain a slightly higher cardiovascular risk for MACE in this group. But again, overall, really no differences between the Tofasitnib and biologic DMARD groups for each of these adverse events of special interest. And I think, again, it's important to point out here that the main limitation of this is reduced or minimal follow-up time at only 1.5 years. Looking a bit further at VTE and DVT and PE separately here, we can see again no increased risk in the Corvitas registry for Tofasitnib, VTE about 0.3 for both Tofasitnib and biologic DMARD groups, and similar rates for DVT and PE here. And there's really not a lot of other real-world data available that has been published that have long enough follow-up and other comparator groups. There's certainly registry data on each of these classes of medication separately, but not in direct comparison to each other. So from Corvitas, we can see, the unadjusted and the adjusted hazard ratios here for MACE, serious infections, herpes zoster, and malignancies, and non-melanoma skin cancer and death. Really, no differences between Tofasitnib and biologic DMARDs, with the exception, of course, of herpes zoster. So this is not a statistical comparison in this table here. This is really just for illustrative purposes. So we're just comparing the crude incidence rates of each type of event per 100 patient years of exposure that were reported between the RCTs here on the left and the real world evidence, that's RWE or registry data here on the right. And just to see, are these incidence rates in the similar range to each other? And I think overall we can see that they largely are. So for JAC inhibitors, serious infections, incident rates 2.5 to 3.3, and biologic DMARDs 3.1, very similar in the registries, 3.1 versus 2.8 over here. Herpes zoster, of course, is higher in JAC inhibitors in both groups compared to biologic DMARDs, but interestingly, the rates in the real-world registry seem to be a bit lower, and I wonder if there's a reporting issue in the real-world registries where maybe it's just not as easy to collect those. But nonetheless, we don't really see any differences for malignancy and for MACE between any of these groups, and similar rates, maybe a little bit higher in the registries where patients are a little bit older, maybe have a few more cardiovascular risks, but in the similar range overall. So no real safety signals from registry studies either, and the limitations, I think, include not a lot of publications on this topic, especially for JAK inhibitors with an active comparator group. But the major limitations being that there aren't a lot of patients with high risks of MACE and of cancer, and a lot of patients with VTE in the past were excluded from a lot of these studies, and so they also are not highly represented in these trials. And I think very importantly, the follow-up duration was fairly limited, certainly less than 3 years, and in many of them actually less than 2 years. So this is why oral surveillance was required by the FDA. And so you're probably all aware that the final results were reported in the New England Journal of Medicine, published on January 27th, just about a month ago, and described the final analysis from the oral surveillance trial. So oral surveillance trial was a non-inferiority design, and the objective was to compare safety, so the risks of MACE and malignancies, excluding non-melanomatous skin cancer, in patients with moderate to severe rheumatoid arthritis who were aged 50 and over and who had at least one cardiovascular risk factor, between 2 doses of Tofasitnib, 5 milligrams or 10 milligrams twice daily, versus an active comparator TNF inhibitors. So for the primary analysis, this was actually a non-inferiority analysis, and this could be demonstrated for the combined Tofasitnib doses versus the TNF inhibitors if the upper limit of the two-sided 95% confidence interval for the hazard ratio was less than 1.8. So why 1.8? Well, 1.8 is a common upper limit that is used by the FDA. Actually, you can find it on their website. And it's the same upper limit of the hazard ratio that was required for the INTRACT study with the etanercept, looking at cardiovascular risk many years ago. And it's also the same upper limit of the hazard ratio that's used for other clinical trials outside of rheumatology, including for cardiovascular risk studies and for diabetes and so on. So this 1.8 is a very common number that is used in many different settings, and this post-marketing study was required to be completed by the FDA. So it started in March 2014, and this is an open label study, but the adjudicators of the study were blinded to treatment allocation. And you can see there were more than 4,300 patients that were enrolled, fitting the criteria that I already described, and they were randomized 1:1:1 to either Tofasitnib 10 milligrams twice daily with background methotrexate, 5 milligrams twice daily with background methotrexate, or a TNF inhibitor, which in North America was adalimumab, or etanercept in the rest of the world, again with background methotrexate. What's important to note is that the mean duration of disease for these patients coming into the study was 10 years, so long-standing rheumatoid arthritis before they were enrolled in the trial. Over 31% were over the age of 65, so almost a third were over 65. And almost half were smokers or had previously been smokers, so 48% of the participants. So there were important risk groups represented in this trial, much more highly than had been in any of the previous studies. So the primary outcome of MACE was reported, and I'll show the malignancy primary outcome on the next slide. And so I'll just draw your eye to the combined Tofasitnib doses versus the TNF inhibitor group here for the primary comparison. And remember, the upper limit of the 95% confidence interval for the hazard ratio had to be less than 1.8. And you can see here that it crosses that 1.8 at 1.94 for this. So in this case, the primary outcome is not met, meaning that the combined Tofasitnib dose was not non-inferior to TNF inhibitors for MACE. And this is showing the same analysis now for malignancy. Again, drawing your eye to the combined Tofasitnib dose compared to TNF inhibitor here, showing the primary comparison, again, crossing the 95% confidence interval threshold at 1.8. So now the confidence interval actually spans from 1.04 to 2.09. And so interestingly, this was not designed as a superiority study, but if it had been, in fact, in this case, it would have been statistically significantly higher in the combined Tofasitnib group. As you can see, the lower limit of the confidence interval does not cross 1. So the conclusion of the study is that the non-inferiority criteria were not met for MACE or malignancy, excluding non-melanomatous skin cancers, for the combined doses of Tofasitnib versus TNF inhibitors in patients with rheumatoid arthritis who are over the age of 50 and have at least one cardiovascular risk factor. So a very different finding than had been reported in any of the previous RCTs or real-world registries. So how do we contextualize these results? How much of a risk is this? And so I think we need to look at the incidence rates for MACE and malignancy and think about the number needed to harm for these. So if we look at the number needed to harm for Tofasitnib, and I'll just draw your eye to the 5 milligram twice daily group because this is the only approved dose that we have available. So the number needed to harm per patient year of exposure is 567. But if we think about it now of maybe treating a patient for about 5 years, then we can calculate the number needed to harm over a 5-year period. So this number becomes 113 patients would need to be treated to have an extra MACE event. In the case of malignancy, we can see the incidence rates now 1.13, and the number needed to harm per patient year would be 276. But again, over a 5-year treatment period, the number needed to harm would be down to 55. So this helps give a sense of how many patients you would potentially be treating and generate an extra malignancy. So essentially, this means that over 5 years of treatment, 113 patients would need to be treated with Tofasitnib 5 milligrams twice daily instead of a TNF inhibitor that would result in one extra MACE event, or 55 patients would need to be treated instead of a TNF inhibitor to result in one extra malignancy. So this is the overall meaning of this study. So why might some patients be at higher risk of MACE and malignancies or VTE? And I think it's important to think about certain risk factors and how we can potentially phenotype our patients and predict who might be at higher risk and be able to use this in treatment decisions. So this is a very useful analysis that was reported by Dr. Charles Schoeman at ACR Convergence in 2021, so just a few months ago. And this multivariate analysis of baseline risk factors can help identify potential independent risks for MACE across all the different treatment groups. And what we can see is that it's very, as expected, the traditional cardiovascular risk factors like smoking, age over 65, male sex, history of diabetes, and aspirin abuse. Of course, aspirin does not increase the risk of cardiovascular disease, but it is a marker of increased risk of cardiovascular disease. So it's really the traditional risk factors that were driving the excess risk of cardiovascular events in the oral surveillance study. I think it's also useful to split up the groups by those with higher risk and those with lower risk, even within the oral surveillance program. And so the age over 65 or ever smoked group would certainly be at the higher risk. And we can see the analysis split by subgroups here. So these subgroup analyses were published or actually presented again by Dr. Charles Schoeman in a different abstract at ACR 2021. And we can see this is the group who is over age 65 with a history of ever smoking. And this is the group who is under the age of 65 and never smoked. And we can see here that the incidence rates for Tofasitnib are higher than the TNF inhibitor in the over 65 group, but they're not higher in the under 65 group. And so you can calculate a number needed to harm for MACE over 5 years at 83 in the over 65 group, but you can't actually calculate a number needed to harm as the incident rate for Tofasitnib is actually lower than it was for the TNF inhibitor group in the under 65 group. And you can see the hazard ratios right shifted over on this graph as well. So that's interesting. And what about for malignancy, breaking up the subgroup analysis again in a similar way? So in the over 65 or ever smoked category, the group who was exposed to Tofasitnib had an incidence rate of 1.38 compared to the TNF inhibitor group at 0.96, whereas in the under 65 and never smoked group, the incidence rates were much lower at 0.7 and 0.44. So we can calculate a number needed to harm in the over 65 and smoker group at over 5 years is 38. Whereas in the lower risk group, the number needed to harm is much higher at 286. What about thromboembolic events? Well, I'll just start on the right side here. So the adjudicated VTE risks are shown over here. The TNF inhibitor group was actually, interestingly, quite a bit lower. So remember I said at the beginning that we expected a VTE range of about 0.3 to 0.5. So the TNF inhibitor group was lower at 0.2 here, and then slightly higher in the Tofasitnib 5 milligram group, 0.33. There definitely appears to be a dose response with the 10 milligram BID incidence rates up to 0.7. But we can see that the VTE number needed to harm is 153 here compared to the TNF inhibitor group. So what are the baseline risk factors that potentially predict the risk of VTE? Well, I think this one jumps out the most. So clearly a history of having a previous VTE event had the largest impact on subsequent risk of having another VTE event. And this makes perfect sense from a clinical standpoint, but it's also quite informative if we're thinking about transitioning a patient to a JAC inhibitor. If they've had a previous VTE, we can see the incidence rate is likely to be 7 times higher than for somebody who has not had a previous VTE event. So just to summarize oral surveillance then, so the non-inferiority criteria were not met for MACE and malignancies for Tofasitnib compared to TNF inhibitors, again, in this higher risk group of patients with rheumatoid arthritis who were over the age of 50 and had at least one cardiovascular risk factor. And the rates of MACE and malignancy were numerically higher for Tofasitnib. With respect to MACE, this mostly occurred in patients who are over the age of 65 or had a history of ever smoking. And it's really these traditional cardiovascular risk factors that seem to account for the majority of the risk of MACE, meaning that the number needed to harm is much higher in patients with fewer or no cardiovascular risks at baseline. With respect to malignancies, the incidence rates for malignancy were numerically higher for Tofasitnib, as already mentioned, and the lung cancer diagnosis was actually the most commonly reported cancer, followed by breast cancer in this study. And again, older age, meaning over age 65, or people who had ever smoked, were the main independent risk factors of malignancy on JAK inhibitors. When it came to venous thromboembolic disease, really low numbers of VTE overall, but still numerically higher with Tofasitnib. And this is actually an extremely rare event, especially in patients who've had no history of VTE before their treatment started. So I think this is instructive. And we had similar risks for serious infections between Tofasitnib and TNF inhibitors. So why is this difference occurring between the oral surveillance study and the previous RCTs and real-world studies that had been reported before oral surveillance? Well, I think there are a few potential reasons for this. And the first is that the majority of patients in these studies, as mentioned, had few or no risk factors. And so enriching the oral surveillance study for cardiovascular risk factors really allowed the number of events to increase and therefore the ability to detect a signal. These are really rare events overall. And so it's important to have a risk-enriched population if you're trying to measure safety events. The second thing is that the follow-up periods were much shorter in RCTs and the real-world studies than they were with almost 4 years of follow-up in the oral surveillance trial. And so longer follow-up obviously is very important for safety. And it's possible that the risk is only increased in certain populations, but not others. And we don't have the data to confirm this. But it's possible that if you have no risk factors, that your risk is not increased overall for certain safety events. So this has led to some statements and warnings issued by the various health regulatory authorities. And I had a look and I unfortunately wasn't able to find any statement released by the Pakistan Drug Regulatory Authority. But I'll just show you the FDA warning, which came out on September 1st, 2021. And the FDA actually applied a black box warning to all JAK inhibitors, so not just Tofasitnib, so also upadacitinib and baricitinib. And they advised prescribers to consider JAK inhibitor risks, especially in those with increased cardiovascular risk or prior malignancy. And of course, this makes good sense. And they instructed them to reserve JAK inhibitor use after a failure of a TNF inhibitor. So really deprioritizing JAK inhibitors overall in favor of TNF inhibitors. Health Canada, on the other hand, recently released their statement and warning on the use of Tofasitnib on January 12th, 2022, so just over a month ago. And they've advised us to use Tofasitnib with caution in patients who are over the age of 65, who are smokers or have other cardiovascular risk factors. But they did not require the use to come after a TNF inhibitor, and they did not apply the warning to other JAK inhibitors. So it's just Tofasitnib that actually has the warning. And earlier in February, the European Medicines Agency has initiated a safety review of JAK inhibitors by PRAC. That's the arm that will carry this out and report back to the EMA and ultimately make a determination as to the label warnings for JAK inhibitors. So we'll see what the results of that are. I think there are a few unanswered questions with respect to the use of JAK inhibitors in the rheumatic diseases. First of all, I think it's unclear if the risks are similar across other rheumatic diseases. We've really only seen data from the rheumatoid arthritis programs, and so it remains to be seen if the risks are similar, higher or lower in psoriatic arthritis and ankylosing spondylitis and other conditions. It's also unclear if the risks are similar for all JAK inhibitors or just Tofasitnib, and of course there are selectivity differences between the different JAK inhibitors. So this remains to be further teased out. I think it's also really important for the interpretation of these results to remember that there is no placebo group or other comparator group that allows us to differentiate whether the increased risk with Tofasitnib in comparison to TNF inhibitors is truly an increased risk overall, meaning an absolute increase in risk with Tofasitnib, or whether this is relatively better improvement with TNF inhibitors. And what I mean by that is we know that patients with active, poorly controlled rheumatoid arthritis are at higher risks of serious infections, higher risks of MACE events, higher risks of cancers, and that treatment of rheumatoid arthritis to low disease activity or remission is associated with reductions in these risks overall. So is it possible that Tofasitnib also lowers the risk but doesn't lower it as effectively as TNF inhibitors do? So that contextualization is just not possible to determine with the data that we currently have available, and I think that's a significant gap. And finally, we don't understand the mechanism by which the risk of MACE or malignancy has been increased by Tofasitnib, and I think this should be studied in future research. So what are the key messages here? Well, the key messages are that the oral surveillance results really underscore the importance of us as providers to assess the patient's baseline cardiovascular risk before starting a JAK inhibitor. We should be avoiding the use of JAK inhibitors as a first-line advanced therapy, not overall, but at least as a first-line therapy in those who are higher risk, meaning patients who are over the age of 65, are smokers, and those with known cardiovascular disease history, as well as discussing the risk of cancer in patients before starting a JAK inhibitor, and deprioritizing or considering a contraindication in patients who've previously had a venous thromboembolic event or patients with a previous cancer. So will I continue using JAK inhibitors as a first-line advanced therapy in patients with rheumatoid arthritis? Yes, I think this is a very important treatment class. It's very effective, and there is an urgent need to treat rheumatoid arthritis to remission or low disease activity, and JAK inhibitors are an effective tool in the toolbox for being able to do that. And I think I will continue using it for patients who are under the age of 50, patients who have no cardiovascular risk factors and prefer oral therapies, but certainly use it with caution in patients who are over the age of 65, and especially those with reduced renal function, as JAK inhibitors are cleared, most of them are cleared by renal excretion, at least to a certain extent. And so in those who are older, it can potentially build up to higher amounts. So with that, I would really like to, again, thank Professor Tofasel and the organizers of the RheumaCon conference, and I wish you a wonderful rest of your meeting. Thank you.